Ovarian cancers are one of the most aggressive gynecologic cancers. Why they are aggressive is because about 75 to 80% of ovarian cancers present in advanced stages, in the third or fourth stages, early fourth stages. Whenever they are diagnosed early, it is usually incidental, but most of the times they are diagnosed in the advanced stages. That happens because the ovarian cancer has a different mode of spread compared to other gynecological cancers. Ovarian cancer mainly spreads via the peritoneal route, and peritoneum is the inner lining of the abdomen, and it is surface area wise the largest organ in the body, as it covers not only the inner part of the abdomen but also all the intra-abdominal organs. So this is the reason there is a propensity of spread from the ovarian cancer, the cancer that originates in the ovary, to any part of the peritoneum, because it has a transperitoneal route of spread. And this is the reason only when there is excessive disease, only when there is heavy burden of disease inside producing lot of fluid as well as the enlargement of the ovaries, that is when the patient usually comes to the doctor. But before that they usually misinterpret or they take it wrong to be a gastric problem. Many a time this happens and they keep on taking over-the-counter gastric medications. So only when they are investigated, they are found to have large ovarian masses or collection of fluid in the abdominal cavity. Yeah, even though they are so aggressive, they are so lethal, and few years before the survival rates of ovarian cancer used to be very dismal, but of late, due to various improvements in terms of the surgery that we do for ovarian cancer, the principles, the technicalities of those, and also various other modalities of chemotherapy, as well as a few immunotherapies, the survivals have now significantly increased. So how do we diagnose ovarian cancer? As I said, they usually present in the advanced stages. But whenever there is a symptom of a bloatedness or a feeling of fullness of the abdomen, some kind of a heaviness in the abdomen, and especially hindrance in performing daily activities, or constipation at times, or feeling nausea. And one of the main, another symptom these women have is they have a history of decreased food intake. Earlier they were having, say, 2 chapatis, but now they can't even have half, or something like this. So these are the predominant symptoms. So if you see, most of them are not gynecological symptoms, but they are rather GI, the gastrointestinal symptoms. So these symptoms, whenever there are, it is prudent enough to get an ultrasound, of course with the consultation of your doctor. And once ultrasound shows such features, then it's better to reach out to your gynecological oncologist for further evaluation. Once diagnosed, we may take a higher investigative modality like an MRI or a PET-CT or a CT scan, and thereafter try to look where all the disease has spread and make a note of it, and then we may obtain a biopsy to prove what is the subtype of cancer. Because although we say ovarian cancer is aggressive, there are certain ovarian cancers which are not that very aggressive. Like there are germ cell tumors which are seen in the younger population, which have a wonderful prognosis, and certain times there are certain other granulosa cell tumors which also have a better prognosis compared to the conventional epithelial ovarian tumors, what are very aggressive. So once the diagnosis has been established, then the decision is made by the gynecological oncologist whether to do an upfront surgery or to give chemotherapy, downsize the disease and then do a surgery. So this is a decision which is done exclusively by the gynecological oncologist, and of course somebody with the peritoneal cancer surgery experience will add to it in terms of looking for the specifics about who are the right candidates for surgery and who are the better candidates for upfront chemotherapy. So whatever said and done, after performing surgery, The intention of surgery, the goal of surgery will be to remove all the disease, macroscopic disease which are seen intra-abdominally, and after that we give a chemotherapy usually through the intravenous route, or also sometimes we give through the transperitoneal route. We place a peritoneal port and we give chemotherapy sequentially to the peritoneal cavity, which has shown higher survival rates. And of late there has been a tremendous survival benefit with something called as HIPEC. What is HIPEC? HIPEC is hyperthermic intraperitoneal chemotherapy, which is we are heating the chemotherapy to a certain set temperature, higher temperature, and that heated chemotherapy is circulated within the abdominal cavity for a period of 60 to 90 minutes. This is supposed to be done only if surgically all the macroscopic disease can be and has been removed, so that whatever disease that has been missed out macroscopically, which is microscopically in fact, is targeted by the HIPEC. So this has been told to improve, this has been proven to have improved survivals compared to those who do not have a HIPEC. But again, there is a way to select who is the best candidate and when do we have to perform that. Apart from this advent of a different modality of chemotherapy, we also have something called as PIPAC, wherein the chemotherapy is, the fluid form of chemotherapy is converted to an aerosol and it is circulated inside the abdominal cavity through a laparoscopic approach. Because the aerosols have a better penetration than a chemotherapy that is given intravenously, or sometimes even a chemotherapy that is given in a fluid form. So this is, although has been having a significant beneficial effect in palliative cancer patients, there are some investigations and there are some research that is going on in upfront therapy also. But as of now, it is mainly in the palliative settings, that is in the recurrent settings rather, and to improve the quality of life. So apart from these surgical techniques, surgical therapies such as HIPEC and PIPAC, we also have immunotherapies, that is targeted therapies which are given especially in women with ovarian cancer who have a strong family history and also have certain genetic mutations which are positive in them. So these are the type of women who benefit from a drug which is taken orally for about 2 years. So with the advent of all these different surgical and medical forms of treating ovarian cancer, apart from doing a good surgery, we are seeing a significant and a tremendous upsurge in the survivals of ovarian cancer patients who earlier used to not have a great survival. They used to relapse or they used to have recurrent issues after the treatment quite early. But now we see that these recurrences, even if they happen, are delayed, thereby significantly improving the quality of life.